Treatment of localized RCC. Greater use of cross-sectional imaging has contributed to earlier detection of RCC in many cases. Between 50 to 70% of the RCC are detected incidentally. Majority of small renal masses. Clinically localized renal cortical tumor up to 4 cm. Treatment with of clinically T1 masses have changed substantially in the past 25 years. While all the small renal masses were presumed to be malignant, therefore managed aggressively, we now recognize the tremendous biological heterogeneity of this disease, and multiple strategies are now available, including radical nephrectomy, partial nephrectomy, thermal ablation, and active surveillance. Each approach has associated risk and benefit, and one approach is best in all circumstances. For example, partial nephrectomy is now accepted as a standard of care in this small renal mass, based in part of the appreciation of the deleterious renal function consequences of radical nephrectomy. Ongoing analysis on the relative merits of partial nephrectomy, radical nephrectomy, and other management strategies have produced vibrant literature and updated guidelines over the past few years. American Society of Clinical Oncology, American Urological Association, European Association of Urology have released guidelines for the management of localized renal mass that provide robust analysis and interpretation of the available studies. Involvement of the urologist with expertise in the management of RCC is essential for the selection of optimal strategy based on the individual feature of each patient. Radical nephrectomy for renal carcinoma. The objective of surgical therapy for RCC is to excise the cancer with an adequate surgical margin. The simple nephrectomy was practiced in many decades but was replaced by radical nephrectomy by Robson and colleague in 1969. Established this procedure as the gold standard approach for localized renal cell carcinoma. Radical nephrectomy as currently practiced may be better termed total nephrectomy, as it often omits several components of the original radical nephrectomy, and which always included extrafacial nephrectomy, adrenalectomy, and extended lymphadenectomy, from the crush of the diaphragm to the aortic bifurcation. Perifacial dissection is still routinely practiced for larger tumor. More than 25% of this tumor extend into the perinephric fat. Removal of the ipsilateral adrenal gland is not longer recommended unless there is suspicious for direct invasion of the gland by tumor or radiographically or clinically suspicious adrenal tumor, because of the similar propensity of RCC to metastasize to ipsilateral contralateral adrenal gland. Finally, the extended lymphadenectomy has been shown to be no therapeutic benefit for patients with clinically localized RCC, as the risk of clinically negative nodes being pathologically involved in less than 5%, and the role of lymphadenectomy in high risk more than PT2N plus M plus renal tumors remain controversial. Radical nephrectomy is still preferred option for patients with localized RCC, such as those with very large tumor, most clinical T2 tumors, or relatively limited subgroup of patients with clinical T1 tumors that are not amenable to nephron sparing approaches. According to 2017 AUA guidelines, physicians should consider radical nephrectomy for patients with solid Bosniak 3-4 complex cystic renal mass, where increased oncological potential is suggested by tumor size. So this RBM, if obtained on imaging characteristic, in this setting a radical nephrectomy is preferred if all of the following criteria are met, like high tumor complexity, partial nephrectomy that will be challenging in inexperienced hand. Second is no pre-existing CKD or proteinuria. Third is normal contralateral kidney and new baseline eGFR will likely be greater than 45 ml per minute per 1.73 meter square. Surgical approach for radical nephrectomy depend on the size and location of the tumor, as well as patient's habitus and medical surgical history. For locally advanced disease and bulky lymphadenectomy, open surgical approach using either an extended subcostal midline or transabdominal thoracoabdominal incision is generally used. And current minimally invasive approaches allow essential step of radical nephrectomy to be performed with the associated benefit of short covalence and reduced morbidity, and laparoscopic nephrectomy is now standard as preferred approach for moderate to large tumors more 10 to 12 centimeter without invasion of adjacent organs, with limited venous involvement or no venous involvement, and having manageable lymphadenopathy. Robotic radical nephrectomy is further extended the indication of this minimally invasive radical nephrectomy, as vascular control suturing is facilitated with this approach, and in experienced hand, minimally invasive approach is suitable for most patients with the localized renal tumors, indicating some patients with features previously thought to mandate open radical nephrectomy. On the other hand, radical nephrectomy has fallen out of favor for SRMs or this small renal masses due to concern about the CKD, and it should be performed infrequently in this population. Several studies have shown an increased risk of CKD on longitudinal follow-up after radical nephrectomy. Hang et al. They first reported 26% of the patient population with a small renal mass, normal opposite kidney, and normal serum creat had pre-existing grade 3 CKD estimated GFR of less than 60 ml per minute, and after surgery stage 3B and higher CKD, they were more common in after radical nephrectomy than partial nephrectomy, 36% versus 5%. And when classifying CKD according to the risk of progression based on the eGFR and proteinuria, proportion of patients with at least moderately increased risk is 44% before radical nephrectomy. CKD has been demonstrated lead to increased rates of cardiovascular events and even death, with proportionally greater impact with a higher CKD stage and lower GFR. And population-based study of more than 1 million subject relative death rates were 1.2, 1.8, 3.2 and 5.9 for eGFR 45 to 60, 30 to 30, 45, 15 to 30 and less than 15. And even after controlling for hypertension, diabetes and proportional confounding factors, and coupled with the biological heterogeneity of this small renal mass, many of which will never lead to compromised survival, the potential negative consequences of radical nephrectomy on renal function have highlighted the importance of nephron sparing approaches.